Welcome everybody to the Wyoming Telehealth Network webinar for July 29th, 2020. My name is Wendy Warren. I'm a program manager at the Wyoming Institute for Disabilities. I normally facilitate our UW ECHO and Education networks, but I am filling in today. So I'm excited to hear. This is a great topic and a great subject, and I can't wait to hear more. I'm going to let the staff from St. John's Living Center introduce themselves because I see you all are in different locations. So I will let you each do your brief introductions and then we will get started with the presentation. I will facilitate questions at the end as well, so I will be reading those and then give you the opportunity to provide some additional information related to those questions.
We're going to be talking about telehealth for long-term care with the St. John's Living Center in Jackson, Wyoming. Let's go to the next slide. We'll start out with introductions. So my name is Lisa Finkelstein and I am a urologist in Jackson, Wyoming. I've transitioned over to the medical director of telehealth at St. John's Health a couple of years ago and have been working with the Wyoming Telehealth Network now for starting to lose track, 2 to 3 years. Watching it grow into something very, very special. And also working with the state of Wyoming also for the past few years, moving the needle forward with telehealth throughout the state of Wyoming. So we'll do the introductions and then I'll just give a quick brief overview. So Cynthia, you want to go first?
Yeah, sure. Hi, everybody. I'm Cynthia Hyper. I'm a licensed clinical social worker here at St. John's Living Center. I've worked in community mental health and I've worked in substance abuse, and I've been here working in long-term care for 4 years now, and it's been quite a journey. And looking forward to talking to you all about telemedicine here at St. John's.
Kelly, you want to go next?
Hi, I'm Kelly Bickham. I'm a nurse practitioner at the Living Center, and I believe the only nurse practitioner hired and based in long-term care in the state.
Melinda.
Yeah, so hi, I'm Melinda Holster, the Executive Director of Senior Living for St. John's Living Center. I've been on the team for about 4 years. Prior to that, just a mixture of experience both in acute care nursing, office nursing, and most recently long-term care and senior living. So I just want to just jump in really quick and thank everybody that's on the call and stepping away from all things related to COVID for an hour. So thank you for joining us.
I agree. I want to thank everybody. I hope that you're going to learn a little bit about the struggles, the challenges, the successes that we've had at our Living Center. We're going to give you a brief overview to start with, and then we're going to take you through the last 4 months as we ramped up. So let's go to the next slide.
So to set the stage, St. John's Living Center, as Lisa alluded to, is located in Jackson, Wyoming. We normally have a population right around 10,000. This time of year, though, I think it's pushing probably 100,000 with all the tourists in town. We are a 60-bed licensed skilled nursing community. We take care of long-term care residents as well as hospice, respite, and also short stay rehab. Normally, about 86% of our residents are 75 or older, which is a very elderly population in our setting when you look at compared to the nation at only 62%. And of our population, about 63% of them carry a psychiatric diagnosis. This will come into play a little bit later in our story. St. John's Living Center also is part of St. John's Health, which provides us some additional resources, as Lisa also mentioned. Our care team is set up like a traditional nursing home or living center scenario, with the administrator, director of nursing, our care coordinators, our social worker on site, our RNs, our CNAs, both of them are primary caregivers, and then our residents and families. Kelly did mention, I think one interesting caveat is that we do have a full-time nurse practitioner who is part of our team, and we'll be also sharing the story of that coming to fruition. A little bit about our culture that I think was beneficial in helping us springboard into a lot of telemedicine is that we are the only registered eating alternative community in our region, which really focuses on developing relationships and person-directed care with the goal to mitigate risks of a senior being challenged with the plagues of aging, including loneliness, helplessness, and boredom. In addition, the Living Center is a CMS 5-star community, so that looks at not just our staffing, but what are our quality outcomes and how well we do on regulatory survey. And probably the biggest thing that I think was a stepping stone in helping us be successful with telemedicine is our mission statement is that life happens here. So both our residents and our care team have always desired that willingness to embrace change, willingness to look outside the box, willingness to go with the flow. And so I think that was a nice segue into looking at telemedicine and taking it that next step with that.
Okay, next slide.
Thank you, Melinda. That was perfect description of us. This slide, everyone, Cynthia is just going to quickly go over a little quick timeline of how we got into telemedicine, and then we're going to go to each one of these 3 items separately. So just in 2017, we had the ability to start with telepsychiatry. 2019, we started with a resident engagement program, which I'll talk about a little bit later, utilizing tablets and then so electronics to connect with families and residents. And then in 2020, of course, telemedicine took flight here at St. John's Living Center. Mostly because of COVID, but we also, but we'll get more into that as we progress. Next slide, please. So that's me again. So telepsychiatry, this is the first foray into telemedicine. In Jackson, and sure as true for many rural communities in Wyoming and across the United States, psychiatric services are very limited. I don't know if everybody has that experience as we do, but this is true across the different places that I've worked in community mental health, substance abuse, and here in long-term care. Specifically in geriatric, in this population, when I came here, there's very little available to people as far as psychiatry services. We had one psychiatrist who occasionally was able to visit and then decided to end services here at St. John's. At that same time, this telepsychiatry became available to us through a company called Telehealth. This was originally contracted through the hospital, through the ICU as part of, Lisa, you might have to remind me exactly why, but it's not essential to our story, but as part of meeting a requirement for regulations in the ICU to have that availability for specialists through burn units. And can you explain that a little bit more, Lisa? Do you remember specifically, or should I just jump ahead?
Yeah, go ahead, and then I'll chime in when you're finished with the slide.
Okay. So anyway, part of the specialties offered through this service is psychiatry. It was provided, if you look at the picture on the side, there's this cart with a computer screen in the top, and it rolls around, and it connects via the internet, and we call it a robot, because it looks like a person, or maybe, you know, from sci-fi, you can remember R2-D2 or whatever that other, I can't remember the other science fiction TV show from the 70s. Anyway, it's a robot, we call it the robot, and the psychiatrist calls into the screen. It's got a wide screen lens and able to see, you know, everybody in the room, and is available as needed. So we can call it anytime and get a psychiatrist at the moment or within a 2 or 3 hour period. So it's wonderful that we're able to utilize that service. And everybody that we've used this with has really thought it's been very beneficial. We've had a lot of success with it. Really, with the medication management piece is so essential in the geriatric population. Really bringing down the overuse of medications, and it's been essential for that. And finding the right medications for this population is very important. So we've had a lot of success with positive, increased quality of life using psychiatric services and having that available to us here at the Living Center. It's been wonderful. Can
I jump in on that? Just for the nursing homes that are on the call, as you're aware, that is a quality measure as far as residents receiving antipsychotic medications. And our quality measure usually sits around 5%, whereas Wyoming and the U.S. sit around 14%. So we have found this a very effective intervention in our comprehensive management of those individuals.
And I want to talk just a little bit more to the challenges of this service. This has been a service that we provided at no charge up to now for this service. It's been difficult to get the physicians credentialed. Lisa could talk more about that, but it's definitely opened the door to other telemedicine applications with Premier Care, et cetera. And also having, and we'll talk about this later too, a doctor on screen is also, you know, a little bit difficult, especially with the challenges with our people with difficulty with hearing or seeing, or you know, challenges with their brain health. Just what's going on with this screen, and we could talk about that a little bit more later on. And so I don't know if Lisa wanted to comment a little bit about that aligned health process now, or move on. It's up to you.
But I think that, you know, I'm sure some people that are on this call are very familiar with these tele-contracted services, which is how telemedicine really got its roots with especially telemental health, which has been around for, you know, many, many years in a virtual way. And so this robot that you're looking at, or whatever you want to call him, ET, but it's basically just a screen to do a video visit. This particular one is through InTouch, which has now been bought out by another company. But it was the beginnings of the programs where we needed to be certified in the hospital to bring us up to a certain level for, let's say, tele-ICU, where rural hospitals needed more acute care ability, and we could use this so-called video visit to hook up with the University of Utah to get acute tele services. So this was something that we could roll into a room and use it for tele-burn, tele-stroke, tele-genetics, tele-anything that your hospital would be contracted with through tertiary care or quaternary care hospitals. Align Telehealth is a separate company that actually is based out of California, But very typical of telemedicine is that they have practitioners, psychiatrists, that live all over the country. And so our particular two psychiatrists that are really just mostly designated to our facility, one lives in Texas and one lives in Denver. So prior to COVID, it was difficult with the licensing barriers, that to get these doctors so credentialed and enrolled in our insurance plan so that we could actually bill for these consultations rather than just paying these contracted rates. I know I'm getting into the weeds, but I'm hoping that the people on the call are somewhat interested in getting reimbursed for these type of visits. But initially, this was all about meeting certain needs and standards for the hospital and our hospitalists and our living center, because we don't have a geriatric psychiatrist. We don't even have a geriatrician. So these are ways, these are bridges using telemedicine that we started to incorporate back in 2017 and even prior to that. Okay, next slide.
Thank you. This is Cynthia again. Moving along the timeline of 2019, the Living Center, we had initial foray into communication with these purchasing, teaming up with a company in Denver called It's Never Too Late. The acronym is IN2L. And they created engagement programming for residents and push it to these tablets. It's they do it all. It's all, they pay for all of it. And it's designed to engage our population, the geriatric population, in different types of programming, trivia, movies, old-time reminiscing things. So a staff member or a family member could sit there with them and go and enjoy some games, or it's just viewing some old movies or something they can remember and really just reflect and have a good time with. Also on this IN2L tablet was Skype. Now, we had no way of communicating, visually with family members who lived out of town, or family members who were unable to come to the Living Center very often. And it just became a really nice tool for families to be able to visually see their loved ones. And this is the first time that anybody used a visual platform for visiting with their family. And a lot of our residents, a lot of our people who are moving here not a lot, but not necessarily the families the kids move here to Jackson, they live here, and then they will bring their parents to Jackson Hole to move into the Living Center. So the parents, they might be from New York or LA or anywhere in the United States and still have family there that they want to be in touch with. So it's been a wonderful tool for those types of relationships, keeping those constant from the video visit. Of course, people still love the regular old telephone, and that works great as well. But that was the first time that we were able to visually see other people across the United States. And this was we purchased these through a grant through the civil penalties monies available through the state. We applied for that grant, and we got these tablets. Now, this company, It's Never Too Late, we had heard about them at a conference, at a state conference, and they are the ones that partnered up with the state to figure out how different nursing homes can purchase these tablets. And they came up with this grant program and said, hey, try it out. And so that's how we got into it. So that was the first time that our residents started talking to families and using digital communication visually. Next slide.
Hi, this is Kelly. And we'll back it up just a little bit to talk about the medicine side, not just our psychiatric services. hired in 2017, Melinda to leadership of the Living Center and realized we really need someone to interface between our residents, nursing staff, and physicians and provide direct care to our most frail, fragile residents that we have. So she advocated for and then was able to create this position of having an in-house nurse practitioner. Several goals: the satisfaction of the patients and their families, the residents and their families, as well as the physicians, the nursing staff, and also the hope to keep up with our CMS regulations for the regulatory visits of face-to-face visits by physicians every 60 days. At this time, telemedicine was not possible for those, as you all know, and there's no means for reimbursement. The requirement was face-to-face. What we quickly realized is it's wonderful to have a nurse practitioner on board, but I couldn't actually do any of these regulatory visits. What I could provide was on-the-ground care at all times. Another note on our timeline, and only in 2019 did we have an electronic medical record. We joined on with Cerner. So we were doing paper charting. We had multiple systems for the physicians trying to monitor their residents, provide care, communicate. So that was actually kind of groundbreaking for us in October to actually have more access and communication available. I don't think we were as responsive as Lisa was hoping in these needs for telemedicine. I think we thought, oh, we've always done it this way and it's worked out fine. And I think COVID was really the thing that opened the door to realize, my gosh, this is an incredible opportunity that we're missing of how to our residents. So it was only in March with COVID that we were able to change the regulatory to televisits, and that is just a waiver currently. That is not something, we don't know what will happen afterwards, but allowing our physicians and kind of we're enforcing it for physicians not to enter because we were on lockdown as a unit. So I was the only medical provider. I've been the only one since March that's been in-house. We did have a few specialty visits come throughout the COVID if it was an urgent medical condition. Our challenges of setting this up, well, first I would say, thank goodness Lisa had done all this background, because as we transitioned with COVID, it was such a smooth movement, honestly. All of our providers were on board and able to just switch to Zoom medicine. That was absolutely fantastic. Challenges of just adapting to it for some of our residents. It's just a different platform. I think they really enjoy face-to-face visits in the home. They like the convenience. It's always been very difficult to move them to actual visits. But some of them just trying to understand what it is. Some with memory issues to know what's actually happening. What's happening? I actually had a very funny televisit recently with one of our physicians where our resident had no idea that she was actually talking to someone in person. So she kept saying, oh my gosh, who is that handsome man on this screen? She was very flattered. So benefits, I think, are pretty clear as we see this. I guess just if we, why waste a good opportunity with COVID? This is a fantastic reason for just to realize how much we now have telemedicine set up in so many ways of just these inconvenient visits or things we've just not been able to offer to our residents because the travel is too difficult. We do have physicians that come to St. John, so that's made it quite easy from Utah specialists. We've been able to do some of that, but just we only have access every 2 or 3 months. Where this way we can access all the time, and I think it's just exciting to think about as we were brainstorming for this lecture with Lisa, realizing how many opportunities we still have ahead of us. For example, ophthalmology. We can actually do our eye visits here and just adding a connection and just purchasing some technology that will allow us to use, tele eye visits or cardiology as well.
So I just want to give, Kelly, I just want to give also a shout out to the Wyoming Telehealth Network, because the reason why we were able to get this rolled out expeditiously and efficiently was because of, as most of you know, the the licensing availability with Zoom, with our HIPAA compliant professional licenses. And so when you have a physician champion or somebody who knows what's going on, it was a matter of just getting the doctors onboarded. And I had been getting the providers licensed as we were, over the past 18 months. And then when the so-called, hit the fan, it was just sort of all hands on deck, get everybody and their grandmother and their mother to get a Zoom license so that we could get efficient and effective care to the patients. And so the Wyoming Telehealth Network and their team was really integral in making this happen for St. John's Health, both the Living Center, everybody in the hospital, and really the physicians in the community. The Living Center was crucial for us because of the restrictions with COVID and the hotspots in these assisted living facilities. Our internal medicine doctors and family medicine doctors that have patients in these facilities were so really unbelievably grateful that they did not have to go in to the Living Center and could do this virtually. Whereas prior to COVID, they were very resistant to doing that. They would stop in, after hours or very early in the morning and see patients. It was sort of a kind of haphazard thing to squeeze it in. But once they realized that they could do these virtual house calls, so to speak, in their office and have these visits scheduled with the patient, it became much more obvious to them that this was really a great way to see the patient. And then they had the beauty of Kelly, who is physically there, boots on the ground, triaging. She is their eyes, their ears, their hands, because that's another reason that the doctors were resistant to telemedicine. They would say to me, Lisa, how am I going to examine the patient using a video visit? And I would say, you can utilize a nurse or a nurse practitioner to be your hands. The patient can also be engaged during the visit. So the fact that we were forced to move into this space very quickly at the turn of a switch, and that Kelly was there, and Kelly knows our providers. She had a very strong background with the doctors in our community. It just made all the difference in the world.
Nice.
Okay, next slide.
Oh, this is Cynthia talking. This quick chart just shows the I just included the psychiatric visits and the PCP visits because that's all we've used it for thus far, with the exception of we've had 2 dermatology visits now since we started COVID. So just in a quick look, you can see small amounts of psychiatric visits growing over the past few years. We're up to 10 this year. Of course, repeat with some patients. And then 72 visits from providers since March, primary care providers. So that's a big deal. So that's just been an amazing resource. That's, next slide, please.
Next slide.
So looking to the future, telemedicine is here to stay. Certainly, we believe that wholeheartedly. It certainly will be nice if we can convince the powers to continue the CMS COVID waiver that we're working under right now regarding regulatory visits in nursing homes being able to be telemedicine versus face-to-face. And then some of the other current challenges that Kelly and Cynthia are going to talk about are the scheduling role, the comfort with technology, and then just the IT side of things.
Yeah. Cynthia will just say, yeah, if it weren't for the IT department, we wouldn't have been able to implement all of this. It's very complicated. Of course, we are connected to a hospital, and I know that's a lot different than a lot of other people who might be on this call. We have a great support there. We're fortunate in many ways because of that. And also, the elder comfort with technology. I know Kelly's had a slightly different experience. She's been on all the primary care calls. I've been on the psychiatric calls. People seem to, I don't know, the psychiatrists, they're right in the face. They seem to set up, and if they couldn't tell you the time, the day of the week that when you walked in, they know everything when the psychiatrist starts talking to them. So I think that's a pretty fun, interesting fact. But I have to hand it to the psychiatrists a bit. Both the two that we have are both excellent geriatric psychiatry practitioners, and the scheduling a little difficult through like telehealth. You have to call up a call center. They have to put the call through. I got phone number. I text the doctors now, find out when they're available, even though they are on call for that day. But I still make an appointment with them so that we are ready for them and we can be set up. I mean, I do that ahead of time because it's just too hard to wait for somebody to just call in and hope they have time and to have a 4-hour window. So it was important to make that connection. And scheduling, I'll just talk about the telehealth with our secretaries. Now, what's happened with each individual office for the providers, they have to call and our secretaries, and then they put it on the schedule. We don't have a scheduling software in place, and we're working on that because we're not a physician office. We're a resident community. So we're figuring out how to make that more automated, and Kelly might be able to talk a little bit more about that.
Well, yeah, and for the medical side, we're really only 5 months into it, but again, so grateful that we already had this platform set up. But for our community, we were changing, the percentages of visits anyway that physician providers were doing, from 100% in person to suddenly going to, 25% in person or less. For us now, we're doing almost all telehealth. So it's just been challenging of how to set this up, but it's a work in progress. And I think, difficult too on top of COVID. There's a lot of stress. So how do we make this as smooth as possible? So our scheduling, a couple of things we had to learn is, no, don't talk to the doctor to set it up. They have someone in the office who's a scheduling coordinator. So once we just worked that out last month, they're the ones who make everything happen. So that will help us reach compliance with just having those every 60-day visits just in the book. Another part to talk about for the psychiatry, the robot, as cumbersome as it really is a fantastic feature. The view is so good, whereas our other visits we're doing either with a phone or a small tablet. It's a very different view that the provider can see in clarity, and I think all that we can work on of just making it better in the future, and then more specific for different providers, of providing more resources so that the cardiologist can actually listen to heart tones, et cetera. And I think our elders will become more comfortable with more consistent technology. And then sustaining the reimbursement post-COVID, I believe we'll be able to continue many of our tele-visits, but I'm not certain what will happen with the regulatory visits, and that's really where it's working with our organizations to just really advocate for continuing this. And then how many visits do we need? Do we need providers to see their patients, their residents, only once a year or in person or twice a year? Or how discussing and how do we want to make this happen? And that moves us on to our vision for growth. I think the greatest thing we can see is how to make this more comfortable, and then how to move in different directions that I've alluded to, of how to have access to more providers that we haven't even been able to see in the past. That we've kind of said, well, at this point, we just can't get you to see this provider, a rheumatologist or an oncologist. Now we can. Now it'll be very easy to make this happen. Also, helping our families, setting up their portal access so they too can become more involved. They can attend for calls, they can find out the notes and access the notes that were written afterward, and just hoping for more engagement. And perhaps Melinda and Cynthia can talk more about the operational and financial outcomes as well as other visions of growth. Oh, and I'm sorry, I do have one more note that's important on this. We'll be moving to a new facility. We will no longer be attached to the hospital, which has been, I think, a nice luxury, medically at least, for our history at the St. John's Living Center. So our movement will be having to have more resources. We won't have radiology, for example. To have radiology, we'll have to transport our residents. So what are some other options we can do? What types of things can we set up? What kind of ultrasounds can we use? A digital technology that a untrained provider can use, which can then be read by either the primary care provider or ED physician, or access to ED telehealth to see if we need to transport or we can do some other care in the meantime. And I'm sorry, I'd love to hear what Melinda and Cynthia have to say about this too.
Yeah, so jumping in on that last vision for growth regarding increased efficiencies, what we've noticed over the past 5 months is just the streamlining of the telemedicine visits and not taking staff out of the building to go with a resident to an appointment, arranging the bus. I mean, people that work in the senior living communities know all the challenges of the coordination of all of that. We also feel that it could be an effective recruiting tool for us for primary physicians that are working in nursing homes, that instead of taking an afternoon off to come and see their patients, like I think it was Lisa that mentioned, they can just be put into the clinic schedule, and it's another visit and the physician just continues his work in the clinic. From a marketing standpoint, I think it's a really neat tool to be able to offer residents and their families that they can do that telemedicine visit with their doctor, with a specialist, versus that adult child taking time off to get that resident to a doctor's appointment. And for us, some of those appointments, you know, are 3 hours from here in Idaho Falls. So we also see this being able to be used in that way. And then certainly quality outcomes can impact that bottom line, from how you're treating wounds and involvement of dermatology and less product use to reduction of transfers to the emergency room, to medication use. You guys, the list is long there, and the impact to the bottom line in regards to that.
Well, I think that's the end of our slides.
Yeah, let's hold on for a second. I just want to go into the chat. Dustin Brown had just a couple of comments or questions. So he says, for your practitioners / specialists that have the mentality of we've always done it this way, what feedback do they give now? So Dustin, I can say that, and I'm going to generalize because there's always the exception, but you know, most of our physicians are unfortunately my age and are very traditionally trained. And it's been absolutely fantastic to see how they have embraced this. A particular physician who has been in this community for over 25 years, internal medicine physician, who really was just not wanting to do telemedicine. When I called him a few weeks ago and I said, how's it going? He said, Lisa, I have 17 patients scheduled today. And and they were all telemedicine. And he had a huge smile. I couldn't see him on the phone, but I could tell that he had a huge smile on his face. And basically, there's no turning back for him. He has totally, and this is really true for most of the physicians. There are a couple that say I have always done it this way and I will continue to do it this way, and that's just how it is. And you know, I have stopped trying to convince everybody. But it's been absolutely phenomenal to watch this transition. Also, Dustin, you asked, can you give a ballpark estimate on reimbursement for a comparison between a telemedicine visit and F2F? Now, I'm not sure what that means. Maybe Melinda or the team knows.
Face-to-face.
Oh, face-to-face. Okay, I had a feeling it was. So, and how close to comparable does adding the Q code, which I'm assuming you're saying that is the originating site Q code. So, you know, as of right now, no problem, Dustin. I should be used to alphabet soup. That the reimbursement with the rules and regulations with CMS, and they really just came out within the last week again to say that they're holding for right now they're extending, as you know, the public health emergency rules and regulations and waivers are staying in place. And Seema Verma, the woman in charge of CMS, is such a telehealth champion, which is amazing. It's a huge feather in her cap, that I have a feeling that a lot of these things are going to remain, that these barriers are going to stay down. So they are paying full parity for codes, and so just as they would be for a face-to-face visit. The Q code, the originating site, is, I'm sure we're still going to have originating site type visits where they were paying about 20, 25 bucks for that Q code. And I spent, you know, the last year and a half building up our originating sites in Pinedale and Du Bois and things like that. But if they keep this barrier down from the home, then that Q code will not be used nearly as often. So the other thing that Melinda, I was wondering if you could or team could address is that when you move into your new facility, and it's, you know, supposedly going to be the state-of-the-art facility and wired for sound, where we can use the tele-otoscope, tele-stethoscope, you know, the pulse ox, the blood pressure cuff, all these things that will be uploaded from as remote patient monitoring into the system. Do you guys have any thoughts about that?
Money.
Yeah. So through the design process for Sage Living, which is going to be our new senior living community that's being erected just adjacent to our living center currently and on the campus of St. John's Health, there certainly is an interest in exploring some of those wearable devices and those methods of telehealth. And what is really challenging is that some of that has already changed since we first explored it 2 years ago. And so it is one of our goals and is front and center as we continue to look at the design for the building. And as Lisa alluded to, just making sure that we have the capabilities for the bandwidth for that type of system, along with our wireless call system that will be new in the building as well.
Okay, there's a question from Andrew. What robot are you using? So that robot is actually mostly sitting in a closet with a blanket over it. It stays very nice and warm and comfortable. So we've really shifted a lot from moving away to the InTouch robot to using iPads and laptops as our video capability. We do have a cart that's going to be rolling out through the U of U, but really, you know, it's not so much about the hardware anymore. That's not what's most important, is the big expensive robots and things like that. Any other questions for the team in regards to taking care of our older folks in their living center and assisted living centers? You guys are from all over. Anybody want to pipe in?
Here's another question that came into the chat privately, and it was, can you ask about any assistive technology for residents who are hard of hearing or deaf?
This Cynthia, some of the communication, part of the grant that we got, where we got some iPads for communicating with families. We also got some speakers, and the hard of hearing, the best thing that we have, the best thing that we found, no kidding, are these comfort audio headphones with a little receiver that amplifies the noise, the sound around them without too much extraneous noise. Some people complain about that with their hearing aids, and it seems to work fairly well for the majority of our people here who are really hard of hearing. Again, it's called Comfort Audio. It's called the Duet. The name of the company is Comfort Audio. They cost $150 on Amazon. The Wyoming, from a conference I went to, there is, and I bet Wind can talk about this. You guys probably know the best about this. Has a, I remember being at a booth where they had some, different equipment, phones and such, that had different ways to interpret or hear, or it would also phones that would put what people are saying up on a video screen, so it would interpret whatever your voice is in the video and put it on a screen on the phone. I know there's a lot of things out, a lot of different equipment like that. We personally don't have any of that here that we're using currently, but definitely be in touch with Wind. They will have more information on equipment like that.
Great, thanks for the shout out. And I will put the link in for the Wyoming Assistive Technology Resources Program. And we do have some great individuals on that staff that could definitely give you some additional ideas. So I will shoot that into the chat box. And we have another question from Randy Miller. I was wondering if I might speak briefly on our experiences. Go ahead, Randy.
Let me see if I can. Yes, thank you. Excellent presentation. The only thing I wanted to briefly add, because I didn't want to steal the show, is our experiences as this works in hospice as well as acute care, pre-op and post-op. For next of kin on the videos, we've found out that the iPads help real well on that. I just wanted to add that to your presentation, which was excellent. Thank you very much.
Yeah, thanks, Randy. I think generally, my motto is telemedicine is medicine, and really there is not one field and one department that cannot be touched with this. And what I would say to anybody, whether you're in charge of an ostomy or a pre-op or sleep, that make it your own. And I think that there is the world is your oyster. It's endless opportunity to engage with a patient in this way. And that's what these groups are for, these webinars. If anyone has any other suggestions to share with the group, this is a great opportunity to do that. How about the Avera team? I see that we've got a big Avera team on here. And I know that you guys have been at this for a long time and that we could learn from you guys.
Talk just a little bit about Avera eCare and our experiences. So we've been doing telehealth in some capacity for about 27 years now. We're in over 30 states, about 500 or 600 locations. Specific to the senior care industry, we're in right around 10 states now and over 150 different locations. Provide a vast variety of different services, everything from 24/7 urgent care support to psychiatry, advanced care planning, discharge, care transition work. We have pharmacy on our team, wound consults. We really have a menu of options when we partner with the site. They're able to come on board and partner with us and pick what really fits the needs of their location. And it can be a skilled nursing facility, long-term care, assisted living, independent living, and we've just started to do a little bit with home health as well here in the last year or so. So very focused on the geriatric expertise and type of medicine. So we're led by Dr. Joseph Reese, who's on the call with us here. He's our geriatrician. And then we require all of our teams to have experience with working with the skilled nursing industry and having some type of extra certification in geriatrics typically to be able to work with the population that we serve. So we've been doing this for quite a few years, and we're always innovating and changing things and adapting as technology changes and regulations change. But it's always a great pleasure for us to be able to assist all of the residents and locations that we work with.
Yeah, I've of course, I think there's no one that doesn't know about you guys because you've been around so long and are so innovative. I was hoping at one point to get out and see your virtual hospital and your virtual services. I would love to do that one time.
We'd love to have you.
Yeah. Yeah, you guys are a great model. Okay, well, thank you for being here. I think Andrew Freeman had a comment.
All right, Andrew Freeman, pulmonary critical care and sleep medicine. I happen to just want to make a comment. There's a lot of talk about from the healthcare delivery point of view. I just wanted to say that in terms of patient acceptance for my private practice patients who I see remotely, especially since March 19th. I'm based in New Jersey, even though I practice sometimes out, and I'm the medical director of the sleep lab at Evanston Regional Hospital, even though I'm in New Jersey. But the thing is, I've been doing a lot of remote patient visits since March 19th when New Jersey got hit very hard, and I'm still doing actually exclusively telehealth for all my outpatients. I think it's important for people to know the outrageous support of the outpatient population of patients. In fact, it far exceeds the support from physicians. Many physicians are cynical and skeptical. The patients absolutely love it. They do not want to go back. And we've even changed, and actually at some point I'd like to be able to, I'll have to talk with the people in the telehealth network, make a presentation about it. I've spoken here before about we've changed some of the ways we do our delivery of healthcare, how to make the visit more meaningful as opposed to just a discussion. But I think it's important everyone should get the feedback of knowing from outpatients the outrageous support. We've reinvented the house call, and I don't think any of the patients want to go back to the old way.
You're here. Totally agree. And I love your New Jersey accent. It brings me home. I'm from Philly.
Yay, Philly, Temple Hospital.
Yeah. How you doing?
Okay.
Let's see. Any other questions or comments that anybody has? Okay. Well, I think we're at 1:01, and Amy and team, you guys have anything else to add?
I just want to tell you I loved being a part of this network today. I usually only get to hear things about ECHO and education, so this was really fun for me, and it makes me really want to join the Wyoming Telehealth Network. So hopefully I'll get the opportunity in the future.